Hello, I'm Joelle Prescott. I'm a nursing student at Frontier Nursing University presenting twin-twin transfusion syndrome, definition, and staging. Twin-twin transfusion syndrome is one of those rare disease processes a provider may or may not see in his or her practice. And it's something that I think draws enough attention and is serious enough for all providers to be aware of. So this is me in the top right. I'm a labor and delivery nurse in Great Bend, Kansas. This is a picture of a twin I helped deliver and took care of. On the bottom is a picture of my son, Ridge. He's 1 year old and he was just thrilled, let me tell you, to write this research paper. So that's a picture of him helping me. So back on track, twin-twin transfusion syndrome. The overall definition is unequal blood sharing between two twins. It is a little bit more complex than that. They have to be monochorionic twins, so that means two identical twins of the same sex sharing a placenta. However, they are unequally sharing the placenta. This is a little picture of how the twins transfuse to each other. There's a donor twin and a recipient twin, and as you can see, the unequal blood sharing causes the donor twin to be smaller, to live in a very scrawny, small amniotic sac, and for the recipient to live in a very large amniotic sac, and this causes a cascade full of problems. So a little introduction on TTTS. This is two twins with unorganized, unequal, chaotic blood flow. This results in a donor and recipient twin. So the definition is, in order to diagnose TTTS, these twins must have a monochorionic pregnancy, which I just touched base on. These are identical twins with a shared placenta. And within the shared placenta, there's something called placental anastomes. This is when there's branching in the placenta. However, to your left, you see that normal placental anastomes share equally. The twins get the same amount of blood. In twin-twin transfusion syndrome, the twins unequally share blood. It is just chaotic. You cannot predict it, and it causes so many problems for these twins. So these anastomes allow blood to travel in one direction versus traveling evenly in two directions. So in order to diagnose twin-twin transfusion syndrome, upon the end of the first trimester, a sonographer will discover a single placenta, twins being the same sex, and a fluid volume discordance. This is going to be touched base on as oliguria and polyhydramnios. So, how the donor-recipient cycle starts. We note that the unequal blood sharing begins allowing the twins to have oligohydramnios and polyhydramnios. This means that there's so little blood that the donor twin keeps that it's not able to make a big enough amount of amniotic fluid. And then this recipient twin's blood level and amniotic fluid level is sky high. It's above the 95th percentile. So, once the twins have been diagnosed with twin-twin transfusion syndrome and the oligohydramnios and polyhydramnios is detected, from this point on, a practitioner would recommend that these twins get weekly ultrasounds and they manage and stage these twins according to the Quintero staging system. So the first stage is the oligohydramnios and polyhydramnios. This means that the donor twins' amniotic sac is below the 5th percentile of the average fluid level, and the polyhydramnios is above the 95th percentile. Second stage in the Quintero staging system, non-visible fetal bladder in the donor twin. This picture is listed to your right in this picture on this slide. So this means that there is so little amniotic fluid that the donor twin is literally stuck to the uterine wall. Stage in the Quintero staging system is chaotic worsened uterine umbilical blood flow. So this means that the blood flow is it's unpredictable, and it is just it's crazy unorganized. So as you can see in the picture to the left, The blood flow to the bottom is pretty even, and then one twin is just receiving crazy amounts of blood flow, and the donor is receiving very little. So in a normal umbilical blood flow, it would be just a nice, organized, uniform wave, which is not what you see in twin-twin transfusion syndrome. Once you get to stage 3, this finding is not reassuring. It's showing that the twins are regressing and not for the better. 4th stage is hydrops. This is when most likely the recipient twin is really feeling the effects of receiving too much blood and having too much amniotic fluid. The twin is developing polyuria. The twin is developing hypertension and eventually cardiac failure, which leads to edema in the hydrops. 5th Quintero stage is a demise in one or both twins. This would indicate an emergency for both the mom and babies, and an immediate delivery would need to be the course of treatment. So this is just a picture of hydrops. It's really important to see how within a couple days, twin A and twin B could be fine, and then a couple days later, you see that this is a significant finding for twin B. The twin's heart is failing, and the whole twin is just edematous. The recipient twin is edematous and really feeling the effects of receiving too much blood. So there is, in addition to the Quintero staging system, there's an algorithm management for twin-twin transfusion syndrome. This algorithm recommends that once you hit stage 1, that the provider just practices what's called expectant management. This means that the provider will order weekly ultrasounds and see this mom and consider this pregnant woman to be very high risk, and to expect the pregnancy to regress and to regress quickly. Once you reach stage 2 through 4, the management is going to be a little bit more invasive. It's going to need to manage these twins a little bit more seriously to prevent further regression. So once these twins hit the 16 through 25 and 5-day week mark in the pregnancy and the second trimester, and if the twins reach stages 2 through 4, this would indicate that laser therapy is recommended. What this would do is a laser would actually cut off some of the placental anastomes and create a more equal branching, a more equal blood sharing between the twins. If this for some reason isn't an option, if the placenta would not indicate that this would be a reasonable treatment, amnioreduction at times is considered. This would mean that the recipient twins' polyhydramnios would be treated. They would drain some of the amniotic fluid, hoping that it would help the mom carry these twins closer to term. However, twin-twin transfusion twins rarely make it to the end stages of the 3rd trimester. Once a pregnant mother's twins would reach to stage 4 through 5, it would indicate immediate preterm delivery. And this would be because once you've hit stages 4 through 5, the hydrops or demise, it's time to deliver these twins to ensure the viability of at least one twin, and it will give the twins the best shot for treatment and for optimal survival. So in conclusion, twin-twin transfusion is a pretty vicious cycle between the donor and recipient. The unequal blood sharing causes a whole cascade of problems. These problems need to be managed by an expert care provider. This care provider needs to be able to do immediate cesarean deliveries in a center where there would be a level 3 NICU. This provider would need to be an expert in laser ablation surgery and also in possible amnioreduction. This provider would need to be able to perform the intensive and pretty complex ultrasounds. And this care for twin-twin transfusion syndrome, the best way to care for these twins is by using the Quintero staging system and following the algorithm proposed and introduced by Simpson and the Society for Maternal Fetal Medicine. Thanks so much for watching.